So today I would like to talk about the new technology. First of all, I would like to thank Sep for inviting me, especially I'm not there. So today I would like to talk about the new technology. We know that orthopedic surgery is the most dynamic specialty in medicine or surgery. It has a rapid advances, curative, and a lot of innovations. Next. Or do you want me to operate from here? But you know that rapid advances has a double-edged sword. When it works, its patients benefit. But one unexpected problem arises that will be disaster for the patients. But the question now, where are we today with the new technology? Evaluations of robotic procedures and implant designs, remote patients monitoring, smart implants, and outpatient surgery and centers of excellence. No, share here. But the fact shows that long-term data of the current the implants designs demonstrate 90 to 95% success rate at a 15 years follow-up. So it is hard to improve a 98% success rate, and there is still a chance that it would be worse. Do you think that CAS, PSI, and robotic can achieve 100% success rate? It's a question, because you know that CAS improved the accuracy of bone cuts and implant placements, but how about the cost saving from better survival and reduce the complications? You know that a lot of publications show that CAS is superior to conventional in improved accuracy and consistent alignments. And this publication from Richard de Steiger look at the Australian registry patients less than 65 years old, the strong evidence of how computer navigation is reducing the number of revisions. But Go-Chin Lee says that registry data only provide a bird's eye view of the situations and lack specific clinical details. So my question, how many of these top world-class surgeons use CAS regularly? We know that the shock in the world, this paper from Sep Parrett and Matthew Abdul, outliers have somewhat better 15 to 20 years survival. So the mechanical axis may be the wrong target in the CAS. And our friend here, NanoCard, shows about the CAS alignment measurement. Is that reliable? Since CAS measurement is in non-weight bearing capsules and closed, and system itself subjective to observer error. And my good friend here, Young Ho Kim, who won the Chitran Award in 2017, presented in the society, there's no benefit of the CAS and do not recommend widespread use of the CAS. While Jones shows here that the CAS usage in the United States and UK is only 3 to 5%, while in Australia it's about 30.8. Given the similarities of demographic, surgeons training, and other surgical aspects, it's difficult to elucidate the reasons behind the big difference. And John Callahan shows here that 38.3% decrease in CAS usage in the United States means that the majority of orthopedic surgeons avoid using CAS. Well, this series, quite big, 20,000 series from Simon Young, shows that CAS did not confer a detectable advantage. So I think move out of this bulky thing, and we have now the handheld navigation systems. Our Malaji shows here that despite its quick registration feature, the iPod-based system shows similar efficacy and a positive step. But Go show here that ABN and CAS group has a significant improved mechanical access, but failed to demonstrate any advantage in clinical outcome in 2 years follow-up. And we published in the core last year, and we look at the accelerometer-based navigation with a systemic review. There's not enough data published to support any functional benefit of the ABN over the conventional replacements. So smart tools need smart surgeons. How about PSI? It's increased accuracy, eliminates outliers, and has a lower operative time and a cost. And Kristen shows that PSI seems promising, no need for additional complex and time-consuming stages during surgery. But if you look at the latest publications, that PSI does not improve the accuracy. So fact number 2 shows that patient demand for a new technology can influence selections because it's direct-to-consumer marketing and the philosophy that the latest is the best. So look at you have to consider for the new evaluations, for the new innovations. A lot of today innovations is fostered by industry rather than academia. A lot of marketing and popularized by a famous surgeon with an untested treatments. So that, but you look at the Michael Dunbar said that still 20% dissatisfied that innovations in TKR technology has a little effect on satisfactions. While Faris Haddad shows here that wondering whether the recent innovations such as custom cutting blocks, navigations, robotic and instrumented tibial insert make a difference that is worth the investment. And fact number 3 shows that new technologies always come with an increased cost because it will add about 40 to 50% cost annually. We know that new technology is expensive, reimbursement will be declined. So this from Michael Bond says that robotic arm appears to be a cost-effective option and potentially provide added value for payers covering TKA. But if you look at cost of these technologies led to preferential use among privately insured patients and at high-volume hospitals. So number 4 fact shows that new technology comes with a technical difficulty. The question, is navigation helpful to inexperienced or low-volume surgeons? The answer is no, because it requires clear understanding of goal of step-by-step and requires significant learning curve. And there's a guideline from the AAOS that shows a strong recommendation for not using the PSI and the CAS. So we move to robotic surgery. We know that it is in nowadays. It is expensive, but uncertain return of investments, longer operative time, and inability to perform soft tissue balancing. Kayani shows here from 40 conventional versus 40 robotics that the robotic has a decreased pain, improve early functional recovery, and reduce time to hospital discharge. But this publication from 2020 core surgeons and hospitals should not use them approaches since they are at cost, have a learning curve, and uncertainty of novel surgical approaches. So no new approach demonstrated superiority over the standard cutting guides on functional outcome. This is gives some illustrations of marketing tools. This patient was operated in a different country, and he come another country. He come to me 14 months later with this kind of X-ray. But the patient said that according to the surgeon, he cannot be blamed because he followed the guide of the computer, of the robotic. This is the result. So if you look at the systemic review and meta-analysis, it's a lot of that shows that robotic and UK not significantly a better range of motions, lower revision rate, and increased surgical time. And this is one of the longest, 2 publications, longest follow-up of more than 10 years from the Korean group, shows that robotic assisted TKA does not improve the long-term clinical or radiological outcomes. And so we have to consider the current concept review by Anthony Chan, who said the continued innovations and future studies with a long-term outcome are needed to better evaluate the role of robotic in orthopedics. And my good friend here, Larry Dorr, in the core this year said that robotic TKA might not show significantly different in high volume or experienced surgeons. While Jay Parfiti says that high-volume surgeon who can afford the robot do not need it, and low-volume surgeon who need it cannot afford it. So I think the drawback of robotic is devices are hugely expensive, require technology support staff, a number of eligible cases per year, improve long-term outcome have yet to be seen. And if you look at the ASKS member survey, 1 in 10 of the AS surgeons reported being a consultant of this robotic company. So widespread popularity of robotic may not necessarily correlate to superior clinical outcomes. At the end, my message is we cannot just be robots of industrialized medicines. Thank you very much for your attention.